Next speaker is. Next speaker.
Yeah.
Oh, okay. It doesn't work. Okay. The next speaker is Dr. Nurse from USA. Clinical and subjective visual results in two targeted refractive groups with an apodized diffractive IOL.
Good afternoon. From personal experience, I've had the opportunity to use about 1,000 Restore lenses since May of 2005 when it was launched in the United States, and overall, most of the patients are very happy with bilateral implantation. As you've heard from previous speakers, Restore gives excellent near vision and distance vision. However, the intermediate vision is functional but not nearly as good in quality. If you take a look at the FDA data with binocular focus curves, you can see the advantage of Restore at the near point compared to a monofocal lens. If you take a look at both Restore lenses in the defocus curves, you can see they're essentially the same both for distance and near. If you target the non-dominant eye to be approximately plus 0.75, you're able to shift the defocus curve of the non-dominant eye and pick up very useful intermediate vision somewhere in the neighborhood of 20/25ths and at worst 20/30ths. Dr. Blaylock also attempted to find ways to improve intermediate vision. He found in the defocus curves that at about 70 centimeters that there was quite a drop-off in the quality of vision with Restore. He elected to achieve this by making the non-dominant eye minus 1.50. And by doing so, he was able to improve the intermediate vision. We did a very small pilot study to test the theory of making the non-dominant eye plus 75 and the dominant eye near plano. And we tested in great depth, distance, near, intermediate, 70 centimeters, and a very lengthy subjective questionnaire. In the process of doing the surgery, as we find there's variances of about half diopter, one of the patients that was set more for the intermediate became more for the distance. If you take a look at the bar graphs, we did find that both for distance and near, both groups were essentially the same, but the patients that had the hyperopic offset did much better at the intermediate vision relative to those patients who were set plano for both eyes. And on subjective results, neither group wore glasses, and the effects of halo, glare, computer use, and shopping were essentially the same. In subjective results, they also were statistically the same. What I do now when I see patients for surgery is I question them very in depth as to what type of glasses they're wearing. If they are wearing straight bifocal glasses and they're interested in Restore, I will set it for plano for both eyes. However, if they're progressive bifocal wearers or trifocal wearers, I will set the non-dominant eye to as close to 0.75 as I can. And in doing so, on an expanded basis, all groups of patients have since been happy.